Welcome to this explainer. Today, we're going to completely flip how we think about tooth extractions. For the longest time, dentistry has been super focused on the mechanics, basically just how to pull a tooth. But looking at modern clinical guidelines, the most critical question we actually need to be asking is when. So think of this explainer as your definitive, simple guide for scheduling dental work around a tooth extraction. Let's dive in. So when exactly is the wrong time to pull a tooth? Well, it's definitely not just some isolated event in a vacuum. A safe extraction relies heavily on the patient's entire medical timeline, especially for our medically complex folks. If you extract a tooth at the absolute wrong moment compared to, say, a joint replacement or right before they start a new medication, the consequences can actually be devastating. Today, we're mapping out the complete life cycle of an extraction. We'll cover scheduling, managing those high-risk timelines, the big antibiotic pivot, what to do on the day of the extraction, and finally, post-op dry socket. All right, kicking things off with phase 1, high-risk timelines and scheduling. The groundwork for a successful extraction actually starts weeks or honestly even months before the patient even sits in your chair. Take orthopedic patients undergoing a total joint arthropathy, like a hip or knee replacement. The guidelines here are incredibly strict. If they need a tooth pulled, you absolutely must wait at least 3 weeks after the extraction before they can have that joint surgery. And on the flip side, if they just had a joint replaced, you're waiting a minimum of 3 months post-surgery before you can extract a tooth. Why? Because you have to give that joint enough time to heal so it can actually withstand the transient bacteria that gets pushed into the bloodstream during dental surgery. Now, this kind of precise scheduling is just as crucial for oncology and osteoporosis patients. For anyone starting anti-resorptive therapies, timing is quite literally everything, because these meds carry a severe risk of medication-related osteonecrosis of the jaw, basically severe bone death. So a full dental evaluation is mandatory. You extract any non-restorable teeth, and then, here is the absolute key scheduling parameter, you have to wait 4 to 8 weeks. Basically, wait until the mucosa has fully healed over the bone, completely, before they start their anti-resorptive medication. You might be wondering, why go through all this scheduling headache? Well, it all comes down to bacteremia. The American Association of Endodontists puts dental extractions squarely in the higher incidence category for causing it. Extracting a tooth just pushes way more bacteria into the bloodstream compared to something routine, like restorative work or taking x-rays. That right there is the exact physiological reason we absolutely have to build these safety buffers into our scheduling. Which naturally brings us to phase 2, the antibiotic prophylaxis debate. So because extractions cause such high rates of bacteremia, the old knee-jerk reaction was just to hand out prophylactic antibiotics. But we are in the middle of a massive paradigm shift. That old standard of giving out just-in-case antibiotics to everyone, it's officially obsolete. The new paradigm is all about strict antimicrobial stewardship. We are aggressively moving away from routine prescribing. And it's for a very good reason. We have to protect our patients from severe, life-threatening adverse effects, like C. diff infections, not to mention doing our part to combat the global crisis of antimicrobial resistance. So who actually gets antibiotics these days? Well, the modern standard limits prophylaxis primarily to patients who are at a high risk for infective endocarditis. And honestly, even then, it's pretty nuanced. For extractions in those specific high-risk patients, the official guideline is to offer antibiotics. But for lesser procedures like scaling, you're really just supposed to consider them through a shared decision-making process. You're constantly balancing the patient's individual oral health status right against the real risks of the medication. To put the sheer danger of overprescribing into perspective, just think about the number 19. For totally healthy patients undergoing third molar surgeries, you would actually need to treat 19 people with prophylactic antibiotics just to prevent one single post-extraction infection. Meanwhile, the rate of someone having an adverse reaction to those exact same antibiotics is 1 in 32. The math simply does not support the collective harm we're risking here. Okay, moving right along to phase 3, the actual day of extraction. When extraction day finally arrives, precision scheduling is once again the name of the game, specifically for those few patients who genuinely still need prophylaxis. If antibiotics are strictly indicated, let's say a 2-gram dose of amoxicillin, it needs to be taken 30 to 60 minutes prior to the procedure to hit the right blood levels. But hey, real life happens, right? Patients forget. If that dose is accidentally missed beforehand, guidelines say you have a window of up to 2 hours after the procedure to give it. But once that 2 hours is up, the window for effective prophylaxis is completely closed. So here's the crucial takeaway. For the vast majority of your healthy, immunocompetent patients, you are not writing a prescription.
period. Instead, strict adherence to local measures completely replaces the need for systemic antibiotics. We're talking copious irrigation with sterile saline, meticulous, atraumatic surgical technique, and giving them rock-solid post-op hygiene instructions. Those are your real primary defenses against infection.
Now, let's jump a little bit ahead in our timeline to phase 4, the post-op window. In those days, right after surgery, managing complications takes center stage. And the absolute most notorious, agonizing, and common one, alveolar osteitis, or what we almost all call a dry socket. It happens in up to 5% of routine extractions and way more often with lower wisdom teeth. It is literally a debilitating condition. The blood clot either fails to form properly or it gets completely dislodged, which leaves the raw underlying bone and nerve endings completely exposed. When you're scheduling follow-ups or handling emergency calls, you need to keep one window in mind: 48 to 72 hours. This incredibly severe, throbbing pain typically peaks right in that 48 to 72-hour window after the extraction. So if a patient is calling you 4 days out, in total agony with pain radiating up to their ear and temple, especially after you pulled a lower molar, you are almost certainly dealing with a dry socket. We also know exactly who is at the highest risk, and this really needs to guide your pre-op counseling. The data highlights some very clear risk factors: patients over 40, smokers, female patients, especially those taking oral contraceptives, and anyone undergoing a really difficult, traumatic lower jaw extraction. For your smokers, you literally have to instruct them to stop smoking for at least 72 hours before the surgery to try and bring that risk down. If you bring a patient in during this window, the clinical exam is pretty textbook. You're going to see an empty socket, completely devoid of a blood clot. The bone is going to look exposed and rough. They're definitely going to complain of a really bad taste and severe halitosis. But here's the crucial part: things like fever and swollen lymph nodes, exceedingly rare.
Now, because a dry socket is not an infection, the treatment protocol is super specific. Do gently irrigate the socket with sterile saline. You actually want to avoid chlorhexidine here because of some rare but really severe allergic reactions deep in the socket. Then apply a soothing eugenol-based dressing like Alveogel, and pair it with NSAIDs for the pain. But don't, under any circumstances, prescribe systemic antibiotics. The only exception is if you are actually seeing objective signs of an active spreading infection, like pus or a systemic fever.
The latest clinical pathways actually reinforce our main takeaway today. A dry socket is fundamentally an issue of delayed healing. It's indicative of local fibrinolysis, which is just a fancy way of saying the premature breakdown of the blood clot. Again, it is not an infection. Because of that, empathetic pain relief has to be your absolute primary objective. You provide the dressing, prescribe the best possible analgesia, and just make sure to review the patient in another 48 to 72 hours.
And really, this brings us full circle to the core ethos of modern oral surgery that we've been seeing across all our sources. We have a dual responsibility. We have to protect our patients from immediate postoperative pain, for sure, but we also have to protect them from the severe, long-term harms of overprescription. The science right now is absolutely definitive. Widespread antibiotic prescribing to healthy populations simply causes way more collective harm than it does benefit. Routine administration is just clinically unwarranted.
So as you go to map out your next tooth extraction, take a really good look at your clinical calendar and your patient's medical history. Ask yourself, do your protocols reflect this new era of timeline mastery, or are you still relying on that prescription pad when you really should be relying on precision scheduling? Thanks so much for joining me on this explainer. I really hope this guide helps you absolutely master your extraction timelines moving forward.